Okay, welcome. This is our fifth in our series of psychological health talks. And what we're going to talk about today is about a book that I wrote back in 2007 called The Prevention of Depression. It's been around for a while yet, but many of the pieces of it are still very relevant today. I'll be talking about some of that during the next 4 weeks and updating some of it, so we'll go beyond the contents of what I wrote in 2007 because there's obviously new information as we go along. But I'd like to start with a little bit of a personal journey. So the idea for this book actually went back a couple of years earlier. So we're talking about probably 2004, 2005, I'm not exactly sure. I was attending at the time a conference put on by the Society of Human Resource Managers. And I was attending a variety of talks, and one of the talks, there was an individual talking about the cost of healthcare for businesses, so I thought I would attend it. One of the slides that he put up was this one. It shows that back in that time, and these numbers are not correct anymore, but the order of cost is approximately the same. What you'll notice on the slide is that the cost of depression, far and away, was the most expensive cost in medical treatments for any business. Now that doesn't mean it's the most expensive medical treatment. Cancer and heart disease are more expensive than depression, but cancer and heart disease tend to be diagnosed late in life. What happens with depression is that depression is often diagnosed earlier in life, and as a result, it is often a repeated cost, and we'll get into that in just a minute, a repeated cost over the span of a person's work life. And so the costs mount up. As I looked at this, I asked the presenter a question. I said, if depression is the most expensive cost in healthcare for businesses, why isn't anyone doing anything about it? And he said, because we don't know what to do. I found myself at that moment thinking, I should try to figure that out. And so for several years after that, including writing this book, I dedicated myself to trying to think that problem through. What is it that we could do that would help people to deal with their lives better so that the cost of treatment for depression would not be so extensive? Now, it led me to a couple of observations that I think are important. First of all, it is the case that mental health treatment is quite expensive. We've seen a lot of changes in the way healthcare is offered these days. One of the things that we've seen is that when you're working with your primary care physician, you're often also interacting with a physician's assistant and a nurse practitioner, as well as the nursing staff and the medical assistants. And there's a variety of individuals who are participating in the treatment at different levels of expertise, because that whole treatment encounter requires different levels of expertise at different times. This is less true in mental health treatment. In mental health treatment, you have a psychiatrist who's expensive, perhaps a psychologist who's also expensive, social workers, licensed professional counselors, marriage and family therapists, all of whom are highly trained and very expensive on a one-on-one basis. That means that there's a lot of upfront cost in addressing mental health issues. Now, it's worth it in the long run, because when we take care of mental health, it does lower not only mental health costs in the long run, but all medical costs. It takes a while for those cost reductions to filter through the system, and that's another issue, but we're not going to get into today. But that means that if we could do things that would keep us healthier and prevent us from becoming depressed, that would be an enormous cost savings. And that's what I began to think about. And I want to share some of those thoughts over the next 4 weeks with you about things that can be done that can help to lower our risk for a diagnosis of clinical depression, and as a result, a more effective, happier, more productive life. So, first question is it depression or is it sadness? I think sometimes we get these two things confused. And individuals are likely to say, if I'm sad, I need to be treated because I don't want to be sad. And that's understandable. But sadness is different than depression. And there's an important difference. So sadness indicates that something in my life is not right. And if I pay attention to that, then I'm motivated to correct whatever it is to make my life better. Sometimes sadness is because there's a loss. We have a person that we love who died, or we lose a job, or we lose something that is of value to us. And in that case, that sadness is inviting us to pay attention to what's important in our lives. When we are going through our normal life and we're not particularly sad, or maybe we're even happy, we tend not to pay as much attention to what's really important. But that's an essential part of being able to live a life that is full and rich and complete. And so sadness in that context can be quite useful for us and quite healthy. What happens is that when it flips into depression, things get stuck. So at that level, the sadness is no longer just sadness. It becomes a lack of energy, a lack of motivation, an inability to see and appreciate the things in life that are of value. It becomes a place where life stops or slows to a grinding level that makes life so difficult. And at that kind of intensity, we call that depression, and that needs to be treated to loosen things back up again, to make it possible for an individual to engage with life, to find what's truly important in their life, and to move forward. So there's a course that occurs. There's a course of depression. One of the things we find is that in about 95% of cases in which a person has their initial depression, if we ask them what event or a series of events were associated with you becoming depressed, in about 95% of cases, people can point to a specific event or a specific series of events that altered their life in such a way that they became depressed. And it's often a loss of an important relationship, or a failure of some sort in their life, or something that they lost where they not only became sad, but they got stuck. There's another 5% that seem to have depression and they don't know that there's a specific cause for it, and we'll talk about that in a minute. But that's that initial depression. There's usually a specific event. Now, one of the things that happens with that is that because there's a specific event, that individual often gets a lot of help. People rally around them. They recognize that they are having a difficult time. They're very sympathetic. They support them. For that reason, most people who have that first episode of depression, in 3 to 6 months, will get better. It isn't the case with absolutely everyone, but in most cases, in 3 to 6 months, they get better. And they go on with their life. And oftentimes, that first episode doesn't engage somebody in treatment. If they were to engage in treatment, there's a probability that they would recover sooner, but many times they won't, and they'll still recover in most cases. Now, one of the things that we used to think about depression is that it was an acute disorder. It had a beginning and it had an ending, and once you had the ending, then you could go on with your life as it normally was. What we find, though, is that when you've had a first episode of depression, about 60% of people will have a second episode within 5 years. And that's bad news, but there's going to be a reason for it, and we're going to talk about that in just a minute. Of those who have had a second depression, about 85% will have a third depression. And if we go back to that initial slide, you remember the cost of depression for the workplace. That's because depression seems to be an episodic disorder rather than a single episode. So each episode makes it easier for a person to be susceptible to a next episode. Here's how it happens. If you're normal and you've gone through a period where you've had a significant loss and you got to the point where you felt depressed, not just sad, that's incredibly painful. If you're normal, you don't want that to happen again. One of the outcomes of that is that you become sensitized to future occurrences that might trigger a similar reaction. So the second episode doesn't require as significant an event to trigger another episode of depression. Perhaps the first episode was one in which an individual was in a very, very satisfying and significant relationship, and that relationship fell apart for whatever reason. The second episode, they might not be in as significant a relationship, and their relationship has troubles, and they spiral into a depression. As a result, in that situation, the support system looks at it and says, well, that's not as bad as the first one. Maybe you just need to get over it like you got over it the first time. And the support system, while it might still be there, isn't as robust and isn't as supportive as it was the first time, making the challenge more difficult. This is the most common time that an individual will seek psychotherapy because they need the support, and they're not getting as much support from their social network as they were before, and now they're looking for additional support. They recover from that, and now there's another problem that they have. So they're very sensitive to subtle changes in their mood because they desperately don't want to have to go through yet another episode. It is the case that not every morning is a morning where we hear birds singing and sun shining and we jump out of bed full of energy. Some days are difficult to get up. A person who's been through a couple of episodes of depression are now much more sensitive to those subtle mood changes. And they're likely to react inwardly by saying, oh my God, is this another episode of depression? And so it seems like this third episode, or multiple episodes after the initial two, can come out of nowhere. It seems like it doesn't require a significant event anymore because the individual is so sensitized to subtle changes in moods that they now find themselves in a spiral of getting depressed easier and easier and easier. If they haven't been seeking medication help, Yet, this is a time when many individuals will look to medication as a potential aid and a potential solution for that depression. So there's a course to it, and each episode can create a vulnerability to a next episode, getting harder and harder to keep that person out of that spiral of repeated episodes. Now, I mentioned that there are about 5% of individuals who might get a depression, and there's not a specific episode that triggers that. And there might be some genetics that are involved with that. There could be medical issues that could be involved with that. There are other sources for the reasons why an individual will have those symptoms of feeling low motivation, low energy, feeling stuck, being pessimistic about their life. And so it isn't always triggered by an initial significant loss, but most of the time it is. So, why does depression happen? There were three kind of traditional things that were offered as potential explanations for why depression happens. We're going to go through them and talk about what they mean, where the fallacies are in each of these, and what they might mean for how an individual can avoid the cycle of depression and prevent it from happening in the first place. So the first one is, it was considered oftentimes, especially in times past, that somebody who got depressed had some kind of moral failing. It was their own fault. You can see how this can happen. The initial event, everybody can recognize, okay, I would feel sad if that happened to me. I can empathize with this person. I can see that they would feel this way. That second event doesn't seem like it's as important. Doesn't seem like it's as difficult. And therefore, there's less support. And there might be a tinge of judgment. Maybe this person is just looking to say that they're depressed to get attention. Maybe they're just wanting us to feel sorry for them. And that's kind of the crux of the moral failing argument. And you hear this sometimes. That person should just kind of buck up. They should think happy thoughts and then they will be better. Or they are just trying to manipulate by going through this. The truth is that most people hide their depression rather than put it out there for everyone to see. So it isn't as common as you would think. And if somebody's feeling the feelings we associate with depression, they probably are not doing that because they intentionally would like to feel bad in order for other people to feel sorry for them. They really are feeling bad. And there are certainly things that are going to be required for them to recover. There are things that are going to be required for them to be able to function over the long term without these episodic recurrences. And so there is a place where effort is required, but not because there's something morally wrong with them or deficient about them, but because once we've had that initial episode, we have to make some changes in our lives to be able to function effectively in our lives going forward. A second way that people have sometimes talked about this is that there might be genetic predispositions. And we alluded to the fact that there sometimes will be some genetics that make a person more prone to depression. Genetics, however, are not things that inevitably lead to a particular outcome. We have really good evidence now, kind of surprising, that somebody who has a genetic predisposition for cancer, their lifestyle choices turn that genetic code on or off. And if they can learn how to live a life that turns that genetic code off, they can have the predisposition and never get cancer because they've never activated it. The same would be true for things like depression, which probably is much harder to find a particular gene or a particular set of genes, we haven't found them yet, that would predispose somebody to depression. And so having a genetic predisposition doesn't mean that you are doomed to be depressed. It's more like a biological habit. Left on its own, it will express itself. But if you can learn things, practice skills that push you in a different direction, it doesn't necessarily lead to depression, even though there might be periods of time in your life where you feel sad. The third common occurrence was maybe it's a brain chemistry imbalance. And this is something that has been talked about for a very long time as a reason for having treatment with medication. And I want to be clear, there are good reasons to have medication as part of the treatment plan for depression. But brain chemistry imbalance is not one of them. In fact, our brain chemistry is changing all the time. As you're listening to this this talk today, your brain chemistry is changing in response to whatever it is that you're hearing me say, and the way that you're incorporating that into your own sense of your life. Our brain chemistry is always changing, and it isn't so simple as we add a little bit of this and take a little bit of that away. Our brain chemistry then fixes itself. Brain chemistries are always regulating. So the idea that we just need a little bit more serotonin from a medication turns out to be far less explanatory than you might imagine. There are other reasons why medications might work, and in future talks we may get into some of that, though we probably won't have time to do much of that today. So I want to talk a little bit about the treatments for mental health and why those treatments are helpful. So the first thing is that I'm a strong advocate, and you wouldn't be surprised at that because I'm a psychologist and a psychotherapist, but I'm a strong advocate that there's a team approach, like we use here at stress management, between the therapist and the medication provider. And if you're going to be serious about treating your depression, to recover from it as rapidly as possible, to get into a place where you can start the process of preventing future episodes, it requires both medication and psychotherapy to make the changes. And let me say in kind of a shorthand way why that might be the case. So one of the things that we know is that when a person is depressed over a period of time, and we'll use that 3 to 6 month period of time in that initial depression as a kind of an example here, that creates at least some minute changes to the nerve cells that are responsible for allowing our brains to work efficiently and effectively. Those changes, that damage to those brain cells occurs because the intensity of the emotion is strong enough that it affects some of the functioning of that nerve cell. And medication, we'll get into how that might help in a future session. Medication helps to address that biological change and helps those brain cells to repair themselves. That's why if you go to a psychiatrist or some other provider and they put you on an antidepressant medication, they will typically tell you that you should be on it for at least 9 to 12 months. You will start to feel better probably within 4 weeks. but you need to stay on it over a longer period of time so that the nerve cells can fully repair themselves and be functioning in the way that they should be functioning. At that point, after 9 or 12 months, if you have been doing work in psychotherapy, there's a pretty good chance that you can then come off of that medication, as long as you have made some lifestyle changes that will help you to change your approach to your life in a way that will reduce the risk for future depression. And that's what the psychotherapy should be about, is learning skills to be able to make changes in your life so that when you're encountering losses and you're sad, you have skills for how to manage that, how to deal with that, how to overcome that, and how to set your life path straight again. Those two things together provide an opportunity for us to recover more fully from an episode of depression. So, as we look at the coming weeks, I want to just preview what some of those skills are that are going to be talked about over the next 3 weeks that help us to change the way that we are living our lives in such a way that we prevent future episodes of depression, or if you haven't been depressed before, could reasonably be expected to make it less likely that you will ever have as serious an emotional disturbance as we diagnose as depression. The first of these is the practice of mindfulness. We'll be talking about that next week. Mindfulness is about becoming more aware. So I'm sad. I need to be recognizing that I'm sad. I need to give myself space to process that sadness and identify in my life what is really, truly important. What mindfulness does is it brings us into a different relationship with our emotions, so that we're not pretending we don't have them, we're not escaping them, but we're using them as signposts, not to wallow in them, not to get stuck in them, but to take that awareness, in this case of being sad, and use it to help myself make the adjustments I need to make in my life to be able to go forward. So mindfulness is the first of those skills. The second one is the skill of optimism. And I'm not talking about the kind of optimism that there's an old joke, a man falls out of a 10-story building, and for 9 stories he's heard saying, "So far, so good." That's not the kind of optimism we're talking about. This is an optimism that is based on a strategy for being able to identify what works in our life, what leads to better outcomes, and how to make that awareness of what's working in our lives something that we can repeat and expand in our lives. And that skill of optimism is a process by which we engage in a systematic strategy to have better outcomes, and it allows us to manage our life more effectively. The third strategy, the third skill, is the skill of resilience. It is unrealistic to think, I'm going to go through my whole life and I'll never have anything bad happen to me. Good and bad things happen every day. Sometimes very difficult and very bad things happen to us. The question is, do we have the skills to not only survive that, but to rebound from that and even grow from that experience, where that ability to bounce back from difficult times allows us to have the confidence that I can meet the things that are going on in my life and I'm not going to be overwhelmed by them. So these are the things that we're going to be talking about over the next 3 weeks. We'll spend a week on mindfulness, we'll spend a week on optimism, we'll spend a week on on resilience, and these are skills that can help you to prevent depression in the long run. Thank you for your attention today. I will be talking with you again next week.